Introduction. Nephritic syndrome is a clinical condition caused by inflammation of the glomeruli. This inflammation damages the glomerular capillary walls, allowing red blood cells and protein to leak into the urine. Nephritic syndrome is primarily an immune-mediated disease and is commonly associated with reduced glomerular filtration rate. Normal glomerular function. Brief recall. Under normal conditions, the glomerulus acts as a selective filtration barrier. It allows water and small solutes to pass, while retaining red blood cells and large proteins within the bloodstream. In nephritic syndrome, this barrier is damaged due to inflammation, leading to abnormal leakage. Pathophysiology of nephritic syndrome. The main mechanism behind nephritic syndrome is immune complex-mediated inflammation. Immune complexes deposit in the glomeruli and activate the complement system. This causes inflammation, capillary wall injury, reduced filtration surface. As a result, glomerular filtration rate decreases. Sodium and water are retained. Red blood cells leak into urine. Clinical features of nephritic syndrome are hematuria. Hematuria is the most prominent feature of nephritic syndrome. It may be microscopic or gross, giving urine a cola or smoky appearance. The presence of red blood cell casts in urine is a hallmark of glomerular inflammation. Oliguria, due to reduced glomerular filtration rate, urine output decreases. Patients may notice reduced frequency and volume of urination. Proteinuria. Proteinuria in nephritic syndrome is usually mild to moderate. It is significantly less than that seen in nephrotic syndrome. Edema commonly appears around the eyes and face, especially in the morning. It occurs due to sodium and water retention. Increased capillary permeability. Hypertension. Hypertension results from fluid retention, activation of the renin-angiotensin-aldosterone system. The most classic and common cause of acute nephritic syndrome, especially in children, is acute post-streptococcal glomerulonephritis. This condition typically develops 1 to 3 weeks after a streptococcal throat infection or skin infection, such as impetigo. The underlying mechanism involves the formation of immune complexes against streptococcal antigens, which become deposited in the glomerular basement membrane. These immune complexes activate the complement system, leading to reduced serum C3 levels. Clinically, patients present with cola-colored urine, periorbital edema, hypertension, and decreased urine output. Most children recover completely, while adults may progress to chronic kidney disease. IgA nephropathy, also known as Berger disease, is the most common primary glomerulonephritis worldwide. It is characterized by recurrent episodes of hematuria that occur within 1 to 2 days of an upper respiratory tract infection, gastrointestinal infection, or exercise. The disease is caused by deposition of IgA immune complexes in the mesengium of the glomeruli, leading to mesangial proliferation and inflammation. Serum complement levels are usually normal, although many patients maintain stable kidney function for years. Some develop progressive renal impairment and eventually chronic kidney disease. Lupus nephritis is a major renal complication of systemic lupus erythematosus and represents an important secondary cause of nephritic syndrome. It results from deposition of immune complexes containing anti-double-stranded DNA antibodies within the glomeruli. This immune-mediated injury leads to inflammation, complement activation, and reduced C3 and C4 levels. Lupus nephritis can present in various forms, ranging from mild hematuria to severe nephritic or nephrotic syndrome. Renal biopsy is essential for classification and guides treatment and prognosis. Rapidly progressive glomerulonephritis is a severe and life-threatening form of nephritic syndrome characterized by rapid loss of kidney function over days, 2 weeks. It is marked by crescent formation due to proliferation of parietal epithelial cells and infiltration of inflammatory cells in bulk space. Rapidly progressive glomerular Nephritis is classified into three main types: antiglomerular basement membrane disease, immune complex mediated disease, and pauciimmune. Glomerulonephritis associated with an NCA-positive vasculitis. Patients often present with severe hematuria, proteinuria, rapidly rising serum, creatinine, and hypertension. Early diagnosis and aggressive immunosuppressive therapy are crucial to prevent irreversible renal failure. The first subtype is type 1, rapidly progressive glomerulonephritis, also known as antiglomerular basement membrane disease. In this condition, autoantibodies are formed against type 4 collagen, present in the glomerular basement membrane. These antibodies bind directly to the basement membrane, producing a characteristic linear pattern of immunoglobulin G deposition on immunofluorescence microscopy. In some patients, similar antibodies also attack the alveolar basement membrane in the lungs, resulting in pulmonary hemorrhage. When renal involvement is associated with lung hemorrhage, the condition is referred to as Goodpasture syndrome. Complement levels are typically normal in this subtype. The second subtype is type 2 rapidly progressive glomerulonephritis, which is immune complex mediated. This form occurs due to deposition of antigen-antibody complexes within the glomeruli, leading to inflammation and complement activation. Immunofluorescence microscopy reveals a granular pattern of immune complex deposition. Type 2 RPGN commonly develops as a complication of other diseases such as post-streptococcal glomerulonephritis, lupus nephritis, IgA nephropathy, and henoch-Synline purpura. Because of complement activation, serum complement levels are often reduced in this subtype. The third subtype is type 3, rapidly progressive glomerulonephritis, known as pauciimmune glomerulonephritis. In this form, there is little or no immune complex deposition seen on immunofluorescence microscopy. This subtype is strongly associated with anti-neutrophil antibody, or ANCA-associated small vessel vasculitis. Conditions included in this group are granulomatosis with polyangiitis, microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis. Type 3 RPGN is the most common subtype in adults and is often accompanied by systemic features of vasculitis. Alport syndrome, a hereditary nephritic syndrome caused by a defect in type 4 collagen of the glomerular basement membrane. Presence with persistent hematuria from childhood, progressive renal failure, sensor and neural hearing loss, and ocular abnormalities such as anterior lenticanus, most commonly X-linked, but can also be autosomal. Electron microscopy shows a basket weave. BBM management includes ACE inhibitors to slow progression and renal replacement therapy in end-stage disease. The lab findings of nephritic syndrome includes increased creatinine levels due to decreased GFR and complement system is activated. Proteins and RBC casts are present in urine. Nephritic syndrome causes acute kidney injury, severe hypertension due to decreased GFR and increased RAS activation, pulmonary edema due to loss of albumin protein in urine and pression to chronic kidney failure.